to the next session. Very often we face a patient in whom heparin cannot be used for whatever the reason. So which are these patients? How long we should stay off heparin and what are the alternatives? So to answer all the queries, we have Dr. Snehal Gaikwad, consultant nephrologist at Imperial Hospital and KEM Hospital, Pune.
Thank you, Dr. Vipul. Good afternoon all. Thank you for the opportunity. We'll move ahead with the talk. It's a very peculiar question given by Dr. Vipul. What to do when heparin cannot be used? Now, we'll see the following. The talk will be as follows. We'll discuss particularly where the situations where heparin is avoided, any specific contraindications for heparin. Particularly, we'll talk about heparin-induced thrombocytopenia. Then we'll go ahead and look at the strategies which we can use when heparin is to be avoided, how to go about it. Then lastly, we'll see when can we restart using heparin in case of major bleeding events. And lastly, a few summary slides to take away the points. So the question is heparin-free HD synonymous with anticoagulation-free HD? What is the take of the house? I am told it should be an interactive session, so please pitch in. Anyone? No. Right. Heparin-free HD is not synonymous with anticoagulation-free HD. It's a colloquial term which we use when we want to avoid anticoagulation altogether. Except, sorry? Yes, sir. Yes. The reverse is absolutely true, but not the forward. So, the clinical situations when anticoagulation is to be avoided is laid down in our guidelines, as in the guidelines: pericarditis, recent surgeries with risk of bleeding, severe bleeding, that's vascular surgery, cardiac surgery, any form of major surgery, coagulopathies, thrombocytopenia, any intracranial hemorrhage, and active bleeding. So, what is the specific contraindication to heparin? That's unfractionated or lower molecular weight heparin. That's heparin-induced thrombocytopenia. Briefly, we'll talk about it. It's an antibody, as we all know, it's an antibody-mediated process in which there is formation of antibodies against the heparin platelet factor 4 complex, and these being mostly of the IgG type, activate the platelets and cause a release in the thrombin and intense thrombosis. This usually the platelet count need not necessarily fall below 1 lakh. Even a drop in the platelet count from 50% from the baseline should trigger the clinical suspicion for HIT. This is more frequently seen in females than males. There's a peculiar timeline for development of HIT. There are two types defined on this timeline. That if the patient's platelet count falls within the first 5 days of exposure of heparin, there might be an history of prior heparin use in the past 100 days, and this is a less malignant version. And the clinical HIT, or which manifests with thrombosis and major complications, usually develops between 5 to 14 days of exposure. The diagnosis is basically clinical diagnosis, which is corroborated with the 4T pre-test scoring and supported by detection of the heparin anti-heparin platelet factor 4 antibodies. Two of the tests which are available are ELISA test, and a platelet activation assay. The platelet activation assay has a lower sensitivity but a higher specificity than ELISA. In this, the patient's the ability of the patient's sera to activate the platelets in presence of heparin in a concentration graded manner is detected. This is more specific for diagnosis. So, what is the 4 pretest scoring system? It is based, the points are based on 4 parameters: thrombocytopenia, timing of the onset of the platelet fall, thrombus, or any other clinical causes of platelet fall are known in the patient. And the points are graded from 0 to 2. So, there is a probability score calculated. If the total score of all these 4 parameters is between 0 to 3, it's a low probability for HIT. When it is 4 to 5, it's an intermediate probability. An intensive workup for the probable HIT should be done. 6 to 8 is high probability and is more likely certain that it is the second version, that is a type 2 HIT, and all form of heparin should be stopped immediately. Then coming to, this is what I have summary table prepared for you all. Type 1 and type 2. the type 1 hit, which is there in a previous exposure was of heparin was there, and the platelet, it's more frequent form seen. It's 10 to 20%, and the malignant version that develops between 5 to 14 days is less frequent, seen in 2 to 3% of the cases. The platelet count fall is more significant in the case of type 2 hit. There is a presence of clinical thrombosis, skin necrosis. There will be repeated clots, the circuit, extracorporeal circuit clotting, and even in certain cases, the access may clot in type 2 hit. Now coming to the alternative forms of heparin, here heparin as an unfractionated heparin or anticoagulation free. This is the general way we go about when we want to avoid anticoagulation in all forms. So we have different options or strategies to deal with such cases. That's a heparin-free HD, wherein only a heparin rinse of the circuit is done. Then intermittent saline, we'll see about what is the correct method, intermittent saline flushes or continuous saline infusion. Then historical, just to complete the list, a few of the options are listed. That's original heparin anticoagulation with protamine reversal, citrate related, then heparinoid mixtures like danapirinoid and fondaparinux, thrombin inhibitors, prostacyclin, serine protease inhibitors, and coated dialyzer, something about coated dialyzer membranes. We'll see one by one. The heparin-free HD as in the conventional heparin-free HD, wherein we avoid using boluses or continuous infusion of heparin during the dialysis. Only a heparin rinse is performed. In this, 3000 units of unfractionated heparin is used in 1 liter of saline to rinse the circuit. Thereafter, this heparinized saline is drained out either by filling the circuit with the patient's blood or normal saline before starting the dialysis. Herein, we are required to keep the blood flows on the higher side. That's more than the guidelines mention 400. It's practically not possible to have such large flows, especially in smaller child patients or critically ill patients. So at least 200 is the minimum required flow to be maintained. Then a periodic rinse of saline is not, though not mandatory, can be done to visualize the clotting in the circuit, or you can use a 200 ml per hour continuous saline infusion. We should avoid blood product transfusion into the during the dialysis to avoid hemoconcentration. When we target a higher ultrafiltration, there is hemoconcentration. So limit the ultrafiltration as much as possible. In case the clotting is detected at the earliest sign, the dialyzer should be changed. And whatever, if saline has been infused during the process, should be adjusted in the total ultrafiltration volume to avoid volume overload in the patient. Similarly, in CRRT, what we can do is the heparin, we can like the previous state, we can use heparinized saline for priming the circuit. Then to minimize the hemoconcentration, the following methods can help. We administer the fluid pre-dilution rather than post-dilution. Then keep the filtration, we adjust the filtration fraction such that it should not be more than 25%. Use intermittent flushes to visualize the clotting. And diffusive techniques are shown to be less, diffusive techniques, there will be less of the filter clotting, chances of filter clotting than convective techniques. Then maintain an adequate blood flow. Now in CRRT is usually done in a critically ill patients or situations like where there is a liver failure or intracranial hemorrhage. So blood flow should be maintained at least 200 as much as possible. Then react promptly to alarm. The technicians have a tendency to silence the alarm, so that should not be the case. Then to reduce the air, blood-air contact in the drip chamber with help of saline. Then avoid overheating the dialysate. And last but not the least, please ensure that the vascular access is functioning adequately. Then coming to the next, this is a question which after I read, I honestly realized that whatever we are doing is wrong. We use intermittent saline flushes of 50 ml or 100 ml every 30 minutes. So when I read through, I realized that it is not the right way to do, because intermittent flushing does not prolong the circuit life, and it is only useful to monitor the circuit clotting. Continuous saline flushing is recommended to preserve the circuit life at a rate of 200 ml per hour. Only the downside is that we need to adjust the total volume in the final UF. There was a beautiful study published by Sagdal et al. In 2006 in NDT, wherein they studied 8 maintenance hemodialysis patients and consecutive sessions were analyzed. All 6 sessions were analyzed. All the patients received 50% of dalteparin dose. In this, in sessions 1, 3 and 5, they used intermittent saline flushes of every 100 ml every 30 minutes. And the alternate sessions of 2, 4 and 6, no flushes were given. Every session was covered with a baseline dalteparin dose to avoid the clotting of the extracorporeal circuit. In this, what they did was, they analyzed, apart from the visual inspection of the bubble trap for clotting and the inspection of the dialyzer at the end, they went ahead and studied the platelet activation by the marker beta TG, then coagulation marker of platelet factor 1 beta 2, and the anti-FXA activity were measured. So as we can see in the tables, the parameters were analyzed as compared to the baseline in both the sessions, session 135 versus 246. So here we can see that the platelet activation, the coagulation factors, then the platelet activation was more significant as compared between the 4th and the baseline. The activity was increased. The platelets were more activated. The mean clot trap, the mean clot score was also increased as compared in the saline flush group as compared to the dalteparin only. So the important findings which the study highlighted was in the they found out that intermittent saline flushes promoted clotting. And even when adjusted by the multilinear regression analysis, saline flushes significantly increase clotting as signified by the increase in the platelet factor 1 beta 2 marker. So I guess we can change our practice to using continuous saline flushes of 200 ml per hour instead of giving intermittent saline flushes. Then coming to the next, that's a regional anticoagulation with unfractionated heparin and protamine. This is of historical importance now because no one uses this nowadays. But in this, what was done was unfractionated heparin was injected into the arterial line and protamine was injected into the venous line. By this, protamine being a basic protein binds the heparin and prevents the forms a stable compound, thereby inhibiting the anticoagulant activity of heparin. But the full neutralization was achieved by using 1 milligram of protamine neutralizing 100 units of heparin. The downsides were that the procedure itself was technically challenging. There was no significant advantages when compared with other lower dose heparin regimes, and protamine itself has many significant side effects. That like there may be anaphylaxis, hypotension, cardiac depression, leukopenia, thrombocytopenia, and always there is a risk of rebound anticoagulation. The half-life of protamine was only 3 to 4 hours versus heparin, that is 6 to 8 hours. So there was always a risk of rebound anticoagulation. And in HIT, all forms of heparin are to be avoided, including this. And coming to the major crux which is followed is a citrate-related anticoagulation. In this, there are 2 ways which we can go ahead with. One is a regional citrate anticoagulation, and second is using a bicarbonate dialysis solution with small amount of citrate. That is citrate, which is commercially known. Very briefly, we all know that citrate chelates the calcium and inhibits the coagulation cascade at multiple pathways. When the ionized calcium drops below 0.5 millimole per liter, it inhibits the coagulation pathway. When the level drops below 0.3, it completely, the cascade is completely inhibited. So this principle is explored in the RCA and the citrate. What happens in citrate when we use a bicarbonate dialysis with a low dose of citrate, so instead of the acetic acid being the acidifying agent, citric acid is used. Here the concentration what we achieve is 0.8 to 3 millimole of citrate is required. In this, the rationale is that when there is citrate in the instead of the acetic acid, it complexes with the calcium and inhibits the coagulation pathway locally at the level of dialyzer. Not the patient does not have a systemic anticoagulant effect, only at the level of the dialyzer. So thereby increasing the dialyzer clearance and increasing the dialyzer use. Sir, but do we use this anywhere? Citrate is used by any centers? No, we are using. Okay. So coming to the RCA, that is regional citrate anticoagulation. Briefly, as depicted in the figure, we inject citrate solution into the pre-blood pump arterial segment before after the sampling port. This when injected, pointer point. Thank you. So there's a citrate solution is injected into a pre-blood pump arterial segment after the sampling port. This citrate then chelates the calcium and reduces it below the intended target, as we said, between 0.3 to 0.5 millimoles per liter. Then there is a post-filter sampling port, which is to take the measure the circuit ionized calcium. Then we inject either calcium-free dialysate, or we can use a replacement fluid, calcium-free or calcium-containing replacement fluid after the sampling port. Thereafter, we set up a calcium gluconate drip. Okay, so the exact method followed with us here is we set the Rizosate at on the pre-blood pump arterial line at 6 times the blood flow. That if we intend the blood flow to be kept at 100, we will start the Rizosate at 600 ml per hour and adjust the dialysate and the replacement fluid with bifossil at effluent rate of 2 liters per hour or 30 ml per kg per hour. Then calcium gluconate solution is prepared in 250 ml of calcium gluconate, 10% calcium gluconate in 750 ml of normal saline. This is set at the 0.5 times the blood flow. That is, if the blood flow which we assume was 100, we start the calcium drip at 50 ml per hour. So we monitor the ionic calcium, potassium and pH from the blood and the ionic calcium from the circuit every 4 hours to adjust the infusion rates. So this is the way we go about. That the circuit ionic calcium is used for the citrate dose adjustment, and the pre-blood pump sampling port was used for the patient ionic calcium. This is helpful in adjusting the calcium dose rate. So coming to the rest of the anticoagulation methods which we can use is by use of heparinoids, 2 of which are commercially used are danaparinoid and fondaparinux. These are particularly useful in patients with HIT. Danaparinoid is extracted from porcine intestinal mucosa, and it targets the molecular weight of the danaparinoid is 5.5 10A, and it is monitored by measuring the anti-10A activity, which is targeted to be at 0.2 to 0.4 units per ml. There is no reversal agent available, and FFP and activated factor 7 are used for severe cases of over anticoagulation with danaparinoid. Now the doses which are mentioned here, only one guideline from Queensland Health has used a beautiful flowchart algorithm to guide the use of danaparinoid. In this, it is based on the patient's weight and the dialysis. After second dialysis is over, before the third dialysis, these the doses are adjusted depending on the either the circuit is clotting or the patient's factor anti-10A activity. So this is even described separately for patients dialyzing twice or thrice a week or using daily dialysis. Because of want of time, we won't go into the detailed reading of this. Then coming to fondaparinux, it's a synthetic, as we all know, synthetic pentasaccharide and has a high affinity for antithrombin 3. It can be used IV or subcute and is monitored by using anti-10A activity. It also has a prolonged half-life, and the dose which is recommended is 1.5 to 5 milligram, depending on the targeting the activity of anti-10A between 0.2 to 0.4. Next up is thrombin inhibitors, that's Hirudin and its synthetic derivatives, and argatroban, which are useful in HIT. Hirudin is, as we all know, was originally discovered from saliva of the leeches, and it was an irreversible thrombin inhibitor. Nowadays, its synthetic variants are available, that is lepuridine, bilaviridine, desuridine. These are all renally cleared and have a prolonged half-life and potential for accumulation in dialysis patients. The dose recommended is 0.03 to 0.4 milligram per kg, and with monitoring of the APTT to 1.5 to 2 times the normal. there is no antidote available for reversal. So if there is an inadvertent anticoagulation, so it has to be managed with FFP or activated factor 7. Word about argatroban. It's a synthetic derivative of L-arginine, and it's a direct thrombin inhibitor. It reversibly binds to thrombin without any interaction with the heparin PF4 antibody. It has a shorter half-life, and it has hepatic cleared, so which makes it an agent of choice for anticoagulation in HATE patients. The dose recommended is 250 microgram per kg repeated boluses, or give a single loading dose of 250 units per microgram per kg, followed by a continuous infusion of 2 microgram per kg. As like heparin, the infusion should be stopped 1 hour before the termination of dialysis. The anticoagulant effect is monitored by APTT. Also with this, there is no reversal agent available. Up next are the prostacyclin. This also is less frequently used. Prostacyclin is, as we all know, is a vasodilator and platelet aggregation inhibitor, and the effect lasts only for 3 to 5 minutes. So it was proposed as a regional anticoagulant. The antiplatelet effects of prostacyclin last only up to 2 hours. The starting dose mentioned is 0.5 nanograms per kg. We begin with a low dose to avoid hypotension and reach a standard dose of 2.5 to 10 nanograms per kg per minute. Up to 40% of these prostanoids are cleared on RRT. The limitations of which are there is no direct effect on the coagulant system, so there is no monitoring, there is no test for monitoring, and has side effects in form of headache, lightheadedness, flushing, hypotension, and it's costly. So next up is serine protease inhibitors, nafamostat and aprotinin, but I'll not read through because these are not used. Last but not the least are coated dialyzer membranes. Since many years, people have been experimenting to come up with various forms of dialyzer membrane to avoid heparin exposure altogether. These such membranes have been coated with dialyzer membranes have been coated with heparin, albumin, or vitamin E in attempt to reduce the dialyzer clotting, surface clotting. As we go through the slide, there are multiple studies which I could not put up for the want of time, but one of which the major inference from these all studies is that these coated membranes with or without heparin or albumin prime have shown to be better than when we don't use anticoagulation altogether. So, but they have not been useful over and above the methods like regional anticoagulation with citrate or saline flushes. We'll discuss only one of these, that's a Hebzorio study. In this, it was an international multi-center randomized control open label study in which 252 end-stage dialysis patients were analyzed, and the first three consecutive sessions clotting free were taken as success. In this, the patients were randomized into 2 groups. One was the standard of care, that is the heparin-free dialysis with conventional membrane was performed either using with saline flushes or pre-dilution fluid, and the study group in which heparin-free dialysis was done with the Gamro dialyzer. In this, the results reported were that using the heparin grafted membrane, there was 20% higher success rate as compared to the control group, and the number needed to prevent the primary outcome of, that is successful first 3 sessions was only 5. The number needed to treat was 5. Then the use of heparin grafted membrane was found to be non-inferior as compared but not superior to the standard of care. The current standard of care, that is using only heparin-free dialysis with conventional membranes, had high failure rate of 50%. And when the post-hoc analysis were done, it was seen that even in standard of care, using saline flushes were better than using pre-dilution fluid. So in nutshell, it was proven that the success rate in heparin grafted membrane was significantly better, thus proving the non-inferiority hypothesis. To summarize, whatever techniques which we have listed till now, each of them has a bleeding complication and severe dialyzer clotting was seen. More so with the regional heparin, the bleeding complications were highest with the regional heparin-protamine anticoagulation, and the most efficacious one of all this is regional citrate anticoagulation. So coming to the last part of the talk, that we all know when to avoid the heparin. So when do we restart using heparin after major bleeding? Whether when we ask ourselves this question, we need to consider the benefits of starting anticoagulation over the risk, and when and how to go about it. So what is the response from the house? When can we restart heparin? Anyone? Any guideline that we know of? So actually there is no guideline, none of the guidelines have highlighted this important issue for our day-to-day use. Only whatever data has been extrapolated from whatever studies are mentioned are about resuming oral anticoagulation after bleeding. Like this, what I have put up is resuming oral anticoagulation after IC bleed. They have evaluated the risk of thromboembolism versus the risk of recurrent ICH, and given us a guideline ki, depending on the risk, high risk thromboembolism patients, we start after 2 weeks, and when the risk is less, we start after 4 weeks. So what do we do? So general consensus is that no guidelines have addressed, so we start it after 2 weeks. Sir, what do we do? Hegde sir, when do we generally restart heparin?
Pericardium is improving. Your basic problem in pericarditis with an effusion is converting into hemopericardium. So if it is improving, I think 2 weeks is that there, at least you have an evidence that it has reduced in size, and you can go ahead and use smaller dose of heparin. Again, you have shown smaller dose or those things, the bleeding complication can happen. So I think better to use low dose heparin and start it and then escalate it to a normal dose. Again, any surgery, again, you know the bleeding, everything healing happens after 10 to 15 days. Our all ESRD patients, they take more time. So usually the suture removal also we give 15 days. So I think 15 days is a reasonable time. Unless they have a more bleeding risk, then we can wait another week or 10 days more.
Thank you, sir.
We still are in dark as to when to use 2 weeks or 3 weeks or 4 weeks. That's a little gray zone.
So, but there in that, even in those situations, they start unfractionated heparin from the day 2 itself at a dose of 5,000 units subcut BD. So, we still don't have an answer whether we should use for dialysis or not. Considering the doses which we use in the dialysis as a low dose is bolus of 2,000, 1,000 or 2,000 and a maintenance dose of 500 to 1,000 units. So, the total dose per session doesn't exceed 5,000 or 7,000. So we clearly don't have a guideline how to go about it.
The main thing will become how confident are we of doing dialysis without any anticoagulant. It's not the same as in a situation where, sorry, you are anticoagulating a patient therapeutically for an event that might happen to him at any time. Here we are looking at a treatment which lasts 4 hours 3 times a week. And if we are reasonably confident that we can do that treatment safely without losing our circuit, without more than the circuit, without the patient losing that volume of blood which is in the circuit, then we might feel more confident about waiting longer rather than restarting. If we are not confident, or if there is a patient whose access is not going to give us the flow, then we would be keen to restart early.
I think reusing the dialyzer tubing is difficult. If you use fresh dialyzer tubing all the time, then it may be easy with the lowest minimum heparin.
Okay. Thanks.
Some centers in US, they don't use heparin also. So because they are single use.
Okay. So finally, if Dr. Vibhul permits, we have 3 slides to summarize.
Yes.
What the guidelines say is for patients with increased bleeding risk, we suggest using regional citrate anticoagulation rather than not using any anticoagulation when you are opting for CRRT. Avoid using regional heparinization, and in patients with HIT, direct thrombin inhibitors, that's argatroban or factor 10A inhibitors like danapirenoid or fondaparinux are better than not using anticoagulation altogether. Then a brief slide about approach to thrombocytopenia in HD patients. As we all know, in hemodialysis patients, whenever we look at the CBC reports or hemogram report, when we see that the platelet count has fallen below 1 lakh or at least 50% from the baseline, we should, and there is any evidence of thrombosis, either in GI, skin necrosis or axis thrombosis, we should look up whether this is manual counting of the platelet count should be done, and whether there is a heparin exposure. If there is an heparin exposure and the manual count is normal, hit should be suspected, and all forms of heparin should be avoided. And last but not the least, this is brief summary slide of the anticoagulants for heparin-free dialysis. All of the lower ones, that is coated dialyzer, circuit priming, or the regional heparin anticoagulation, are fallen out of favor. And the ones which are more useful are the regional citrate anticoagulation or mechanical saline flushes, that is continuous saline infusion in 200 ml per hour. Thank you. Any questions?
Thank you, ma'am. So I actually chose the speaker wisely because this is a completely gray area. There's no guidelines, and she is the best person to dig out the evidence and